you all coming out and spending some time on kind of a challenging topic in some ways. So before, obviously, I kind of get into it, I really want to share, obviously, I guess, who's talking to you, and to also kind of share maybe some of my own inherent kind of biases. And then I want to spend a few minutes trying to get a little clearer sense of you all, so that I can really try to make this hopefully as helpful and kind of impactful as possible. So, who am I? Well, I have a love for the ocean. Hence, you'll see a lot of kind of water-based slides throughout my talk. My name is Amy Cheshire, and I wear a lot of different hats, but professionally, I'm a licensed clinical social worker. I've been at the University of Rochester Medical Center. Um, Gosh, I'm starting my 33rd year. Um, yes, I was only about 5 when I started. Um, but I joke around a lot at the U of R that I don't know if there are probably some retired U of R folks I'm imagining in the audience. But at the University of Rochester, can anyone guess what you get after 25 years of employment? A watch? Good guess. Any other guesses? It's very fitting. What's that? Oh, deck of cards. Wow. Okay. That actually happened? Okay, well, maybe things have changed. You actually get a rocking chair, believe it or not. And if anybody has been to my office, you would have seen this. It's a lovely uh, wooden, very high quality. It has the University of Rochester symbol, their emblem, that's of course imprinted onto said rocking chair. When I first really got started there, I actually walked into a nurse practitioner's office in neurology, and she had said rocking chair there. And I said to her, "Oh my God, this is such a nice chair." And she's like, "Well, you stick around here, Amy, for 25 years, it's going to be yours too." And lo and behold, that's what's happened. So I don't know what happens next. Like, I think 35, do you get like a walker or really nice walker though, right? A four-wheeled one with the emblem on the seat and the whole 9 yards. So we'll see. But it's just been a real privilege to work at the University of Rochester. I have to say, not that this is some info commercial for them, but I got the opportunity. I started in the Department of Psychiatry, and there's nothing like working on inpatient psychiatry, what we call neuropsychiatry. People that have been in the community think of it as the R wing over at Strong, if you've been around a long time, which I never even knew what that meant. Um, that's where you really get to see the kind of the hardest of the hardest, and sort of people that are struggling with both neurologic disease, things like Parkinson's disease, things like Alzheimer's disease, things like Huntington's disease, as well as having a lot of significant psychiatric issues, hence why they're in a locked, secured setting. And in those days, when I first started, people stayed for long periods of time, long months and months, which never really happens anymore. But you really got a sense of what is it like here for somebody that's kind of going through this. And then flash forward to about 2000, the year 2000, when I got recruited over by the movement disorders group, who had never really, interesting enough, had a social worker per se that was on their staff. And they were very nurse driven, which is wonderful and great. We love nurses. And they really wanted a social worker, and they were becoming centers of excellence for Parkinson's disease, as well as Huntington's disease. And so I got recruited over at that point and have kind of remained there ever since. And I kind of get to do a lot of different things in my role because I also kind of help coordinate our clinical trials research program, because I think, you know, people often ask what's sort of most important when you think about something like Parkinson's disease. Is it trying to really help people right now that are very much living the disease, right, day in and day out? Or is it really trying to help find an answer, i.e. research, so that we can either slow down, stop, or prevent Parkinson's disease altogether? Those are hard choices to kind of grapple with, right? Because both are essentially probably really important. And so being able to do a little bit of both has been really impactful for me. And in terms of my Parkinson's role, has a number of years ago, maybe almost 9 or 10, the original chapter, the Rochester chapter, I forget the official name. Do you remember, Kevin, the official name of the? Right. Kind of had this long, right. It told you exactly what it was, I guess, right? And at the heart of it, obviously, was a lot of different things. And certainly the support groups was a big piece of the original organization. But they came up with a really unmet need back almost 9 or 10 years ago. In particular, Dr. Michelle Burak. Is it show of hands? Anybody know Dr. Burak, right? Okay, so she's a former faculty at the U of R, movement disorders neurologist. She's very involved with RPN as well, I know, and on the board. But Michelle, or Dr. Burak, really identified that, yeah, we see a lot of people with Parkinson's in our clinic. On average, we see about 1,200, 1,500, Jillian. Jill Lowell's in the back. She's my colleague from the U of R as well. And of all those hundreds and hundreds of people that we see with Parkinson's disease in any given year, that there is just seemed to be this kind of hole, if you will, in the services that we were trying to provide to people that are dealing with Parkinson's. And what was that hole? It was this sense of, you know, I always say, if there's anything, a common theme with Parkinson's disease is really this sense of loss, right? And you'll see this embedded a little bit more in my talk. And Dr. Burak really recognized this. And when I say loss, I'm talking about a lot of different losses, right? Loss, once somebody gets, and we'll talk more about this, a new diagnosis, that's a huge loss, right? That's a fundamental shift in how I think about myself. Then there just get to be, or can be, multiple losses that start to pile up. And the thing, you know, with the beauty of aging, okay, is that this phenomenon called compounded losses, right? So you barely kind of get hit with one loss, right? And let's say in this case, a new diagnosis of Parkinson's disease, before maybe a whole nother or different loss hits you, and you've barely kind of recouped from your Parkinson's diagnosis, and now you're having to deal with maybe a new health problem or something else has happened in your family. And so these compounded losses just start to build up and build up and build up. And we really weren't doing a great job maybe at the clinic in trying to help people. Yeah, we were really good with managing motor symptoms, medications, referrals out to physical therapy, speech therapy, all these things that are incredibly important, okay, to Parkinson's disease. But I think she recognized way back then that this sense of what about people's sort of other experience with Parkinson's? They probably need more support, i.e. probably in a counseling kind of environment to help with these sort of, I don't know, people call them a lot of different things, but sort of the softer, I always hate that term, softer symptoms of Parkinson's disease, and how to cope with these sort of unrelenting losses and changes and transitions that are going on. So she got an idea, she presented it to the board way back then, like 10 years ago, and they then decided to outreach to our clinic. For people that know Dr. Rich Barbano, a well-beloved, been at the University of Rochester for many more decades than me, and approached him and said, hey, we want to try to work with you all. Can we pull together a program, a counseling perhaps program, to help people with Parkinson's disease to deal with these other pieces of Parkinson's disease that are just as impactful, create just as much disability as a lot of the things that get more of the press, and rightly so, in terms of what people call motor symptoms or the physical signs of Parkinson's. And so that's how it all started. And he subsequently approached me and said, they're going to have some small seed money. You know, we want to do this. We have a couple of really strong aims about the program, that we really want this to be as easy as possible for people to get counseling support, right? Because there's so many barriers. If anybody, and hopefully there are people in the room that have tried or needed to get mental health services or counseling services, that even in our, you know, lovely Rochester, Greater Monroe County, there are so many barriers to getting that type of help, right? Whether it's trying to know, who do you even call? Where do you even find somebody? How do you find somebody that knows hopefully something about Parkinson's disease? Will they take my insurance? Is it going to have to be in person, or can they do it virtual? There's just so many barriers. And so we wanted by this program to knock those all down as much as we could. And that's what we were able to do in partnership. And that has continued on. Now, flash forward 9 or 10 years later, to be able to do that. And that's a big part of what I do, is trying to continue with that program where we can see people on a short-term basis. We're not charging insurance. We're not having to deal with medical insurance. It's all right in the clinic, so it's pretty seamless. You're going to the same place that you see your neurologist. So trying to help with those barriers. And so that's just kind of a big part of what I'm doing in terms of actively with Parkinson's disease. So that was a long-winded way about me. So maybe briefly, if I can, just to get kind of a little bit of the lay of the land of you all, can we just do, to kind of just know who you are? So maybe a show of hands, how many people in the audience? And if you're not comfortable doing this, don't do it, okay? How many people have Parkinson's disease themselves? Okay. Oh, great. Okay, so that's a good chunk of people. All right. What was that? It's not great? What do you mean? You said great. Oh, okay. Well, you are. Okay. Oh, boy. All right. It's going to be a rough room. I can tell. Okay. No, it's funny. Isn't it interesting how you interpret things, right? Like, I see it as great because I think of, like, good Lord, you have Parkinson's disease, right? Just sometimes getting up in the morning and getting the first foot out of bed is an act of courage. So to extend that and see all these people, or a good chunk of people with Parkinson's here, made it here, I have to imagine your morning might have went a little bit differently than people in the audience that don't have Parkinson's disease, right? That's why I was impressed. Gotcha. Great in that kind of way. All right, so who is maybe a spouse of someone with Parkinson? Okay, so a good chunk of the room. Okay. And how about any adult kids, adult children of someone with Parkinson's? Oh, okay, really small number. Okay, just the two of you over there. Oh, 3. No, I mean an adult child that's here because of their parent has Parkinson's. Okay, so that's kind of interesting. All right. And are there other categories that, is it just interested people? Oh, okay. Friends that, what do you call yourselves? Caregiver. Good Lord, yes. Oh, a sibling. Sibling of a person with Parkinson's. Is that right? Okay. What was that?
No, I like that term, helper. That just sums it all up. You help people.
Helper.
Yes.
Yeah. instead of caregiver?
Well, it's just catchy word.
Right, helper. Okay, all right. Did I miss anybody? No, sounds like we covered it all. Okay, so it's a nice kind of cross section, and like I said, I'm always really glad to see people that have Parkinson's. So let's move on. All right, so um, again, I think it's helpful to know who's talking to you, not only about what they do and that kind of thing, but sort of where they come from. And so, hence why I have a picture of my mother and father up in the presentation. And my dad actually had Parkinson's disease and passed away from Parkinson's disease about almost 7 years ago. And it's interesting, when you have a parent, right, that suffers from a disease that you've spent most of your career working in, right, you would think, right, that my father would have just listened to every darn thing I had to say about Parkinson's disease, right? Of course, okay? And I wish I could stand up here and say that was the case. But it was a humbling experience in many ways because, as I don't know, most people take sometimes a long time to get to a diagnosis of Parkinson's disease. That I would say is more common than uncommon. Okay, long time meaning from when you first notice something is a little bit off or different about yourself until you finally get to kind of hear the diagnosis. That for some people, that's a long road of maybe many years. For other people, it's much shorter. But with my dad, right, I started noticing symptoms actually in photographs, believe it or not, where, as many people may be aware, there, because of some of the loss of dopamine, that people can get a little bit sort of more of a flatter sort of affect, a little more mask-like. I don't like that term, but especially around facial. And that's interesting enough what I myself really noticed. And then as time went on, other symptoms started to crop up. But it took my dad a long time, right? Because I didn't know what I was talking about. Okay, right. And, what do you know about Parkinson's, Amy? Okay. But I carry that story of my dad and his journey with Parkinson's disease, which had a lot of twists and turns and ups and downs. The other thing I should bring up is that I was born and raised in Southern California. So all my family, including my parents, lived out in California. So I also had that different pressure of long distance caregiving, which has some pluses and minuses to it as well. But also getting to see my mom really walk through this experience as a helper or caregiver, as that gentleman said. But the reason I bring this up is just that I professionally, of course, have worked in Parkinson's, but I really try to also bring this piece of it as much as I can. As someone that's never had Parkinson's, I really try to bring sort of the family perspective into my work as well. All right, so why does anyone think I have this slide? Okay, right? This is supposed to be a highly professional, polished, it's being recorded, it's going to maybe be out, in the online world. And the reason that I have this slide is because it's true. Okay, to simplify it, right? When I say it sucks, which I know is probably not wonderful terminology to use, but it's the term and something I hear so often in my office, I can't even begin to tell you, okay? And I think it's true. And we need to be, one of the things I really hope today, and maybe this is the beauty of being at work for a number of years, is that I don't tend to kind of mess around anymore with platitudes or trying to kind of make it all nice for everybody. I try to be real as much as I can, right? And I think this is part of that, is that when we're talking about transitions, okay, and when we're talking about transitions to generally perhaps higher levels of care, right, that tends to bring up a lot of anxiety and a lot of, I hate this, right? Those are genuine, true, real, honest feelings, okay? And the more that people are able to kind of express that and be okay with it, and for me to be okay trying to help people to recognize, yeah, it just sucks. Sometimes, some days is not doesn't suck as much, but in general, this is hard things. People are doing incredibly hard things when you're talking about the changes that are coming about, how to manage the transitions, how do we do all this. So I don't want to lose sight of it's also to try to bring a little levity to kind of a, a challenging topic, but I don't want to lose sight of just sort of this kind of harsh reality. And the other flip side of that is that, yes, it's hard. And thank God you all are here trying to hopefully get some little pieces of information to make it less hard. But the bigger thing that actually that you may not even realize in some ways by coming together like this is that what happens, hopefully, you all don't feel so darn alone on the path, okay? That there can be such power and grace and a lot of intangibles that when you're part of a community like this, that we can't prescribe to you, that I can't give you a prescription for, okay? But carry a lot of weight, especially when you're talking about a topic like this, about transitions, knowing that, ooh, okay, that guess what? Everybody else in this room probably has other things they might have wanted to do today, okay? That might have been hopefully maybe even a lot more fun and joyful, but you're here, okay? And you're here together. And there's just a profound, and I can't even really emphasize it enough, how critical that is to make this path, which sucks and is hard and is going to have a lot of bumps along it, just a little bit softer, okay? Just this sense of, because I know one of the primary indicators, just both from research but from practice, is when care partners, when families, when people with Parkinson's start isolating, pulling back, not going out, they're not calling, we're not hearing from them in the clinic. Guess what's going off for me? Like big red sirens, okay? Because that means generally isolation is starting to happen. People are pulling back. People are feeling like nobody else is getting it. Nobody understands what I'm going through. It's not even worth it anymore. All these really profound sense of leading on a path of kind of despair almost, that's when people get into trouble, big trouble, okay? And so this sense of community can go a long way in really trying to almost be an antidote or to really kind of help buffer that so that people don't feel so alone. Can I just, a show of hands, do most of you feel like you're kind of in this on your own? Does anyone, or I have to imagine since you're here, that do you feel like you're on it on your own or you're in it with everybody else? Does anybody want to share? I see a nodding of heads, so so maybe it's resonating a little bit. Yeah, go ahead, Kevin.
Or having a family member or a spouse, child, or a parent. Think about the 4,000 to 5,000 people in the Rochester area that have already been diagnosed,
Right.
let alone all those people that have symptoms, have not yet been diagnosed, are on that long trajectory of those for the moment. people that have been diagnosed,
Yeah.
there's at least another 4 people who are affected by that diagnosis, either the spouse, or the child, or the parent, or the colleague.
Right.
Now we are talking about 25,000 people in Rochester who
Yeah.
are not
Right. Right.
in
Yeah.
a city
Yeah.
with 500,000 people. 5,000 are affected by Parkinson's.
Right. Yeah. Yeah. That's a great point. Yes. Um, yeah. Do people agree with that? I don't know if you're surprised by the numbers. I appreciate, hearing the specifics, that just how widespread. So hopefully this, um, will be less of a problem because of knowing all of that. I also know that this shifts. It's a long journey, right, with Parkinson's, and that at various points it's going to be normal in some ways to maybe feel a little bit more alone with this than other times when people may feel less of that. Also, to let people know that. But the more that we can really try to um, have people feel a sense of community, it's just profound. So let's move along. Okay. How about a show of hands? Maybe people can close their eyes no, and not look at this slide. Has anybody heard of the Hone and Yar scale? Just Yvonne. Okay. What's that? Oh, you did too. Okay. So a couple of, okay. What do you know about it? Just interesting. Is anything? Okay, right. Did anyone, do you want to say anything more about it, Yvonne? Do you know? Yes. Absolutely. Super, very well put. Yes. Very impressive. You sound like a clinician there, Yvonne. All right. So, a couple of things that I think are interesting about the beloved Hone and Yar. Okay. Look when it was originated. Can everybody see that? What year does it say? Right, 1967. So, quick math. How many years ago was that? Who's good with math? 58. Okay. Wish I had a prize for you. Okay. Yes, 58 years ago, this scale was first designed by 2 physicians, and you can see their names. Hence, in those days, we really liked you got to name your scale after you. How cool is that, right? Like, okay, so 58 years ago, we still, so flash forward to 2025, this scale is still used extensively, okay? It's not a one-off, it's not something we think about, both in clinical practice, i.e. when you come and see your neurologist or whoever you happen to get to see for your Parkinson's, but also in research. A huge piece of clinical drug trials are based around this scale. And when I say that, that means for anybody that's participated or hopefully will participate if you haven't in research, to be involved in a clinical trial, there's things we want you to have, what we call affectionately inclusion criteria, right? You need to have Parkinson's disease, for example. You need to be of a certain age, these kind of things. And then there's things we don't want you to have, okay? What we affectionately call exclusion criteria, okay? And so the beloved Hone and Yar scale, all right, is used rather extensively across many, many clinical trials, both in the past, currently, and probably in the future with Parkinson's disease, to really evaluate, depending on where somebody is on this beloved scale, whether or not you can participate in our trial. Okay, so it is a scale that has years of validity to it, for one, obviously, but just the extent that we are still relying so much on a scale that was developed a long time ago. I think that says a lot of different things. Think about how many things, from 58 years ago that we're still using in our lives, right? So it has kind of stood the time, the sense of time. And the reason I bring it all up is that the staging, right? Because one of the things that's so often asked, but in a lot of different ways to me and to my colleagues is, can you guess what it is? What's one of the most common questions someone with Parkinson's disease has when they come in to see a clinician? Any guesses? How long do I have? Okay, wow, okay. Yeah, that's it. Okay. Which is right. Maybe another way of saying that is also what? How bad is it going to get? Right? The way that we often hear it is, what stage am I at? Right? Okay. How many of you have probably, either you yourself, you have PD, or your person that is with you, have in some ways tried to ask your doctor this question, right? And I bet you've gotten some pretty universal responses. Do you know it, right? And what is the physician, not to down physicians at all, we love them. What do they tend to say to these questions? Right. And isn't that helpful? Incredibly so, right? Okay. Okay. Right? And the reason that you tend to hear that is because there is, of course, some degree of truth to it, right? That everybody is so darn different. All this variability within Parkinson's disease, okay? And one of the ways that we try to lessen this variability is scales like this, okay? And so I do think it's helpful for people that are living with all of this to understand that at some level, okay? Because this is what is kind of going through your physician's mind in some ways, especially if they're probably a movement disorders neurologist, when we're thinking about how is somebody doing? How do we answer that question, okay? And the reason I'm bringing it up in this talk is because this staging of Parkinson's very much correlates, right, even associates, dare I say, with where somebody's living, what's going on with them in terms of their social environment, how long they might be able to stay with where they're at, and what the future holds for them. So understanding kind of where you're at in this, or where your loved one is at, is really a nice kind of framework, I guess, to understand what can I expect, what is going to be needed with these upcoming transitions. So let's just walk through this kind of rather quickly, because you can read up here, right? We think about this in 5 stages, typically, okay? And the early stage, where people often, this is when diagnosis is first happening, people are just affected one side of your body, what we call unilateral, okay? Just one side of the body is starting to have symptoms. Then with progression of time, okay, symptoms move on to both sides of the body, or what we call past the midline, okay? And this is often, in particular, I put up about speech, or the scale, not I, the scale talks about an example of what goes across the midline, the middle of your body, is speech abnormalities. At stage 3, now symptoms are really continuing to evolve, I should say, both sides of the body, but now what's the big thing up there? Balance, right? Balance. Balance is an enemy and a friend sometimes with Parkinson's disease, right? It's a huge piece of this scale, though, and many scales, other scales, not just the Hoehn and Yahr, for Parkinson's disease, focus in some capacity around balance. And balance has a lot of direct correlations with what? Walking and falling, right? And what do walking and falling in any type of neurologic disease, but in particular something like Parkinson's, are lead indicators of people not being able to stay at home anymore. Okay, there are other ones, and we'll talk about them, but those are two big ones. Okay, and so you can see, so at stage 3, what moves somebody into stage 3 is this issue about now balance is getting impaired. All right, by stage 4, symptoms are continuing to advance. And now, although someone can still technically stand and walk, right, without needing somebody else, you are having really significant disability and needing at least some degree of help with, sorry to use the acronyms, ADLs, activities of daily living, bathing, eating, toileting. That's what we mean by activities of daily living. So you're needing more and more help with all of those now because of all this cascade. And then by the end, by stage 5, not the end, but stage 5, really person is needing help of someone else or something else to be able to stand and to walk. Right. Any questions about that? Because there's going to be a quiz after. So, okay. So, Hoehn and Yahr. All right. So, what's the problems with this scale, and why is this important? Okay. As somebody I think already picked up and commented on, I think it was Yvonne mentioned this. What does this scale do? It only looks at what? Motor symptoms, right? The physical symptoms of Parkinson's disease. Now, again, keep in mind when the scale was originated, right? So 58 years ago, Parkinson's was really, really defined as only a motor disorder, right? And it's still a motor disorder. But guess what's happened? We have come now 58 years forward to understand all the non-motor signs of Parkinson's disease, okay? So it really only focuses on motor symptoms and doesn't really, not only not talk about non-motor, okay, but because we're not talking about non-motor, then we know it's a lot of these non-motor symptoms, which can be the gamut, right? Do people know, I'm sure, this is a very well-educated audience, when I'm talking about non-motor symptoms, right? Which can run the gamut from depression and anxiety to constipation, to problems with your speech, to a variety, a whole battery of these non-motor. And those non-motor, believe it or not, and even our research bears this out, tend to more likely create as much, if not more, disability, okay, than your motor symptoms, right? And these non-motor symptoms can also put people at higher risk for not being able to maybe stay where they're at, or maybe they're in a place right now and they might need to move to a place for a higher level of care, often because of the impact or the inability to manage or treat, in particular, these non-motor symptoms. So it's important to recognize that. And again, there's no timeline, which is really interesting about that scale, right? The 1 through 5, okay, is that, and I just put up an example here, people can stay in that stage 2, right? So I've got symptoms on both sides of my body now because of my Parkinson's. I can stay there for a long time. When I say a long time, we're talking years, okay? So that's kind of, I think, the good news when you're talking about a progressive scale, right? And even decades, many people will never even, not a few, will never even get to stage 3. And what happened in stage 3? Let's see how good people's recall is. Balance, right? Okay, so there's a lot of things about the scale that are great, a lot of things that aren't, but it is a huge piece of the practice of Parkinson's. And if you hear it from your doctor, well, you could even impress the hell out of them, okay, by telling them, or you could ask them, what stage of a Hoehn and Yahr do you think I'm in? Okay, they would be blown away, all right? I'm just telling you, okay? So that is about the scale. Okay, so now let's talk about the real world, because that's why we're all here, okay? Oh, we're gonna take a break? Should I take a break right now? Okay. Yeah, well, maybe we'll take just like 10 minutes, maybe? Okay, before we get into kind of the real world. Sound good? Okay.